All right, well, I wanted to welcome everyone for a very special edition Morbidity and Mortality Conference here at University Hospitals. Today we have the pleasure of having Dr. Nayak, Dr. Schmotzer, Dr. Salata, and Dr. Armitage joining us for updates on COVID-19. So the way that the conference will run is we will start with a brief introduction by Dr. Armitage, followed by a presentation by Dr. Schmotzer and Dr. Nayak, and then finishing up with Dr. Salata. So now I'll hand it over to Dr. Armitage to introduce us.
Yeah, thanks, Kiara. And I think Leith is going next after me. But if you could just show my slide. Can you forward, Kiara? Yeah, there you go. I just wanted to set the stage very briefly. This is a slide bar from Leila Hojet that tracks what's happened at Cleveland Medical Center, which I think reflects what's been happening in the community. If you look at the slide, you can see we're really in our sort of fourth wave now. We had this little peak in April and May, another peak in July, our biggest peak in December, January. And we hit a low of 5 patients on March 23rd, and then we've been increasing to it since over 30. What's been remarkable about this most recent, fourth mini surge, whatever you want to call it, is that with the exception of 2 very immunosuppressed patients, none of the admissions have been vaccinated. So 100% of the immunocompetent patients admitted with COVID since the middle of March have been vaccinated, which to set the stage for vaccines and the variants in this middle mini surge, I'll hand things over to Dr. Nayak.
Thank you. I will put my slides up.
So I just want, while Dr. Nayak is pulling it up, I just want to give a brief introduction to everyone on who Dr. Nayak is. So after completing her internship at Lincoln Medical and Mental Health Center, Dr. Nayak went on to complete her internal medicine training at Allegheny General Hospital and research fellowship at the University of Louisville. She then made her way to Cleveland, where she completed a fellowship in hematology oncology in 2011. Joining the faculty in the Division of Hematology and Oncology here at University Hospitals, Dr. Nayak's interests lie in understanding the molecular mechanisms involved in the generation of an increased risk of thrombosis, particularly in the setting of malignant disorders.
Right. So it's.
Yeah. I have a granola bar too sometimes. What do you get?
Everyone, please mute.
Good afternoon, everybody. And I would like to thank Dr. Armitage for offering to give me a spot today. All of this is fresh, hot off the press, as you will see, and there has never been a dull moment for the past year with the virus and now with the vaccine. So without further ado, I will start because I have a bunch of slides to go through. And so this is now what we're calling it. After HIT, we have VIT, which is vaccine-induced immune thrombotic thrombocytopenia. The clot really is getting thicker here. We start with a case. SL is a 40-year-old lady with a history of a right subdural hematoma from a traumatic event in February. She's otherwise stable, and that hematoma as well is stable. She presents to an outside hospital on the 16th of this month, so April, and please note these dates because these are important, with a headache and leg pain for 1 day. She denies fever, nausea, vomiting, no new medications. And a CBC was done, I guess because she had this subdural hematoma in the past. And her platelets were noted to be 27, which were otherwise at baseline a few months ago. So she does not have a hematological abnormality or disorder that we know of prior to this event. A fibrinogen was 141, so low, and a D-dimer of more than 35,000. A COVID-19 test was negative. And she happened to mention that she received her Janssen COVID-19 vaccine 9 days before. Again, bear in mind this date because this is important. She was then admitted to this hospital, and for 3 days, in my mind, these were 3 painful days for me because she was transfused with platelets and cryoprecipitate as her platelets kept declining and her fibrinogen kept decreasing. They consulted hematology on the 19th, so 4 days later. A smear was reviewed. Hematology thought this was ITP, so immune thrombocytopenia, and they instituted IVIG and dexamethasone, which would have been appropriate for someone with ITP. A Doppler at that point revealed bilateral lower limb extensive DVTs, So popliteal, tibial, peroneal, and with declining platelet counts at a low of about 10, the team decided to transfer her to main campus university hospitals for further management. So the outline of my talk, and with that I'll go through this. There are reports, as we all know, of unusual site thrombosis and thrombocytopenia following some of the COVID-19 vaccines. We'll go over the background of CVST, how we approach and manage this, and then a summary. So we know that as of April 9th and I want to say 21st, there have been 3 cases or presentations of thrombotic thrombocytopenia after the chimpanzee adenoviral-based COVID-19 vaccine. These have been associated with unusual sites of thrombosis and thrombocytopenia. And this is the timeline. The initial reports came in March, and the hematology community has stayed tuned to all of this. There were 7 patients reported, all with CVST, so cerebral sinus venous thrombosis, which is a very, very rare thing to occur. 3 of these died. 3 of these patients died. And then by April 9th and 16th, there were these cases and manuscripts that have been since published in the New England Journal of Medicine. And then on April 17th, the ISTH, so the International Society of Thrombosis and Hemostasis, issued this statement on the AstraZeneca COVID-19 vaccine and its association with thrombosis. So the AstraZeneca vaccine is a chimpanzee adenoviral-based vector vaccine. And so what are we doing in the US? Oh, sorry, this one. So in the US, we have the Janssen COVID-19 vaccine, and this is a human adenoviral vector-based vaccine. This was approved on February 27th, and we started vaccinating our first patients on March 2nd. On March 19th, so within 2 weeks, we reported our first case of CVST with thrombocytopenia. And since then, we have 6 cases till April 12th. On April 13th, the CDC and the FDA recommended a pause. And as of now, they are investigating these cases and newer reports in close collaboration with experts in vaccine immunology and hematology. We hope to hear back from them very soon. But let us talk about CVST. So these are very, very rare occurrences. This is a very rare disorder. And in general, form a very small proportion of all strokes. Seen in young people, there is a preponderance in females, and usually associated with a risk factor. As you can see, there are always some risk factors associated. These do not develop spontaneously. Commonly presenting with a headache, and then other features that you would expect that would go along with increased intracranial pressure, so vomiting, papilledemia, visual problems, focal deficits, seizures, and then mental status changes. And then there are rare occurrences of, which we are seeing a lot of in these patients, subarachnoid hemorrhages, intracerebral hemorrhages. So what do we know about all the vaccines that are present and available to our people, our patients here in the US? So the Janssen COVID-19 vaccine, remember this is an adenoviral vector-based vaccine. And it is associated so far, it is the only vaccine out of the 3 that are available that is associated with CVST with thrombocytopenia. I would like you to keep that in mind. It is not just CVST, it is associated with thrombocytopenia and a consumption coagulopathy, as you will see, which makes it so unique. And out of the 6.8 million doses so far, we have 6 cases, which is a reporting of about 0.87 cases per million. But bear in mind that we saw these only in females. With the Pfizer, there are no reports of any CVST or any thrombosis or unusual site thrombosis in the 97 million cases or million doses administered so far. And with the Moderna vaccine, we have seen 3 reports so far out of the 84 million patients or doses that have been administered, but none of these were associated with thrombocytopenia. So again, what we're seeing with Janssen and AstraZeneca is a very unique phenomenon. What do we know about the characteristics of our 6 patients? Very young, all below 50 years of age, and they all presented within 13 days of their vaccine. All so far have been females. And I would like to just pause here and remind you that when the phase 3 trials of this drug, of this vaccine were ongoing, if you remember, there was a pause in the study. And that was because there was an unusual site thrombosis at that time in a young male. So the details as we know of it now, as it was a healthy, otherwise healthy 30-year-old young male who came with, presented with cerebral sinus venous thrombosis, went on to develop thrombocytopenia, then developed intracranial hemorrhage and subsequently succumbed to that illness. So I would not say that this is only a female related event. Granted, it is more common in females, but we cannot forget that you might see a male patient with this. And there was no association with estrogens or any other illness, pregnancy, postpartum. So there is nothing else that we can attribute this thrombotic event to except this association with the vaccine. What did our patients present with? Headaches, all of them, or something that suggests a thrombus in that area. So the last patient presented with abdominal pain had portal vein thrombosis, as you will see. And then the late features were, of course, deficits. And then did they present with anything else? So if you look, 4 out of 6 of these then went on to develop intracranial hemorrhage. And then 3 out of all of these had thrombosis in other places. A lot of these are in portal veins and splanchnic vein thrombosis. So again, unusual site thrombosis, not something that we usually see. All of them had thrombocytopenia. And then out of the 6, 5 of them were tested for the PF4 hit antibody. All 5 were positive. And let me add here that these are wildly positive. So very, very positive, very high ODs, much higher than what we see in hit. And that you will see in our patient as well. The treatment for all of these was either heparin, as these were new patients. We did not know what the underlying diagnosis was. None of these patients had had an exposure to heparin, bear in mind. So they received heparin and they still did better. Their platelet counts improved. Once we realized that their PF4s were positive, they were switched to a non-heparin anticoagulant. In this case, all of them received adagrasib. Some of them received platelets because they were significantly thrombocytopenic, probably bleeding. And then 3 of them received IVIG. Out of these, we lost 1 patient. So the first patient died. Out of the remaining 5, 2 were still in the ICU as of April 12th. So when you see an association, you say, is this because we are vaccinating millions of people, or is this actually causation? And to do that, and I do not have time to go into the details, but I'll be happy to explain it to anybody later. What we did is they looked at the incidence of CVST as we know it, and then they looked at what should have been the reported event if it was just an association. And then if you look further, you will see that the reported or expected cases in women in this age group is far, far lower to what we are reporting. So at each of these, so from 0.5 to 2 is the reported incidence for just CVST. And when you divide it and look at each of these age groups, and each of these, at every stage, we see a far higher incidence or reporting incidence in these patients, suggesting a strong causation between the vaccine and these events. So very quickly, this is what an algorithm that the ISTH has put in, and stay tuned because this is going to change every week as we have more data. So your eyes do not see what your mind does not know. And so, today is my time to explain to you what is out there so that when you see a patient, please bear in mind and hold a high index of suspicion, because otherwise we'll miss these patients. We do know that early diagnosis and institution of treatment will save lives and will prevent morbidity. So please bear in mind that if anybody has had a Janssen vaccine in the past, we're saying 13 days, but with the AstraZeneca, they saw cases up to 24 days. So we're not out of the woods yet. The last doses were given on April 12th. We are expecting to see some cases, as we saw our first patient here. And so if you have anybody with the history of a J&J vaccine and have some of these symptoms that are suspicious, then consider VITT. Quickly screen for VITT with imaging and an urgent stat CBC. If the CBC has a platelet count of less than 150,000, at that point, I would call hematology. But the other things to do is a quick assessment of the coagulation status of the patient, the coagulation assay, a close fibrinogen method, which is what we do at our institution for a fibrinogen activity, a D-dimer, and then a platelet factor 4 antibody with a hit ELISA, which is the most reliable. And again, that I believe is done at our institution. The PF4 ELISA will take time to come, so we do not wait for that, but the OD readings are extremely high, which would confirm VTE. We will not wait for confirmation. We will start treatment immediately, suspecting VIT at this point in time. And although I've given what we are doing right now, it really is very tailor-made for every patient, depending on how low the platelet count is, depending on how low the fibrinogen is, and whether there is bleeding or not in our patients. So yes, IVIG, steroids, avoid platelet transfusions, which is why I said those were painful 4 days when this patient stayed in the hospital, received platelet transfusions, because obviously we were not aware of this entity at that point. But all we would do, this patient received platelets and cryo, which would mean we're fueling this immunothrombotic process in the absence of anticoagulation. We are suggesting that we not start heparin or low molecular weight heparin, even though this is not a hit, just to bear caution at this point in time. And a non-heparin based therapy would be better. And in case our patients do not improve with any of this, then we would consider plasma exchange. And so this is the timeline, and this is how they expect patients to improve with their D dimers coming down by day 4, and the fibrinogen and platelets will come up as the treatment takes effect. And that is exactly what our patient is doing. So when she hit the door on Monday night, her platelets were at a dismal 18,000, fibrinogen at 60, and a D dimer of 54. We started IVIG, argatroban, cryoprecipitate, and steroids, not necessarily in that order. So my fellow and I had a very long conversation at midnight on Monday to decide what to do. We were fearful of starting argatroban with a fibrinogen of 60, but to give cryo in the absence of anticoagulation is really not a good thing to do. So we had to be very judicious with our therapies, and I think it worked. We sent out a PF4, which has come back as 2.4, which is consistent with VITT. Her MRV has been negative for a cerebral sinus venous thrombosis. And of course, we would do a complete workup. We cannot assume that every patient that has had a Janssen vaccine has come with a thrombotic event is going to be VITT. So Sangi Hong, my fellow, did an extremely thorough differential diagnosis and workup, which has all turned out to be negative for all the other thrombotic thrombocytopenias and consumption coagulopathies that we might see. Hematological and hemostatic parameters are steadily improving. And as of now, I consider this our first case of VITT at our institution. So to quickly summarize, bear in mind that CVST is extremely rare, is associated with a high mortality and morbidity, and is not usually associated with thrombocytopenia or a coagulopathy. We have already seen 6 cases in association with Janssen. I would say ours is our 7th, and there must be more. All 6 that are reported so far were women. Our patient makes the 7th for us at least, all associated with thrombocytopenia. She was 40 years old, so she fits this criteria. She has no other risk factors. And all of these have been associated with the adenoviral vector vaccines. None have been associated with the mRNA vaccines. The clinical features are similar to what we have seen with the AstraZeneca vaccine. And stay tuned, because the diagnosis and management is evolving and will change. I'd like to end with one sentence. Remember that the thrombosis that we see with COVID-19 is far, far higher. And so please go out and get vaccinated. With that, I'll thank the audience, and I'm happy to take any questions, which we will do at the end of all the 3 talks. Thank you.
Awesome. Thank you so much.
And Dr. Marija is going to introduce our next speaker. So.
Yep. I'm going to stop sharing for a second, pull up the PowerPoint again, and then I will go ahead and, all right. So now we have the pleasure of having Dr. Schmotzer here. So Dr. Schmotzer went to medical school actually at Case Western Reserve University, and then completed her residency training in anatomic and clinical pathology, as well as a molecular genetic pathology fellowship at Emory University. She then joined University Hospitals in 2009, and she currently serves as the Director of Clinical Chemistry, as well as the Medical Director for the UH Translational Lab. We're very lucky to have her here today. And Dr. Schmotzer, I have your slides pulled up, so I'm happy to advance, or if you prefer to share your screen, that's also okay.
Okay, can you hear me? Can you see my screen?
Yeah, perfectly.
Make sure. Whoops. Slideshow going. Okay, are you seeing the slideshow now?
We're not seeing it in presenter view, but we're seeing the slides.
Hold on. How do I change that?
Go to the bottom right next to the different sizings. There is what looks like a projector sign, bottom right of your screen.
I'm not seeing that.
So it's at the very bottom where it says yep, right there on the left a little bit. I see your cursor.
You see my cursor?
Yep, go straight down. Straight down all the way. Yep, right there on the left, a little bit more. Right next to the minus sign, there's what looks like yep, perfect.
Okay. Now are you seeing the slideshow?
We are not.
You're not.
The other thing you can do is you can just pull the slides in the side over so it looks like a slideshow. There we go. Yay.
Oh.
Yep. You
Yes,
just have
now?
to- Yep.
We were a second ago. It may depend on what you're sharing.
Okay. Okay, I'll, Kiara, if you could take over.
I have your
share
slides.
screen.
I have your
Yes.
slides, so
Thank you.
I'll
Sorry
take
about
over.
that.
Yep. I got it. All right.
Okay, thank you. Always some technical challenges on the Zoom, so I appreciate the opportunity to come and talk about some of our testing challenges and questions that we've been getting related to COVID-19, particularly associated with variants and vaccines right now. So what I have here is the three kind of categories of testing and questions that we are getting right now. A lot of questions about variants. So what's circulating, how are we detecting them, and what's out there, as well as specific patient cases. Vaccine, so we have a vaccinated patient who has a post-test positive or post-vaccine positive. Is this a breakthrough from vaccine? Is this a variant? And then antibodies. So we have, again, post-vaccine, we have a lot of questions coming about response, particularly in immunocompromised patients. Next slide. Just to orient everybody on the terminology, as we talk about variants, we talk about variants of interest, variants of concern, and variants of high consequence. All of these things are intended to categorize the risk of emerging lineages which have changes at different points along the SARS-CoV-2 genome that convey a potential risk of changes to receptor binding, neutralization of antibodies, reduced efficacy of treatments, potential impact on our diagnostic tests, or predicted increase in transmissibility or disease severity. So as you can see, it's a spectrum here. And the spectrum is really both increasing severity as you get to the variants of high consequence, but also increasing evidence that those impacts of those mutations are having on those different categories. Next slide. The variants that we know fall into these categories right now, there are 4 that are classified as variants of interest, 5 that you see highlighted in red here that are classified as variants of concern. And these are the ones you'll be hearing about in the literature as well as in the press. And there are no variants categorized as variants of high consequence at this time. What we know is that these variants of concern tend to have either increased transmissibility or may have these what are called substitutions of concern. So these are specific point mutations that have demonstrated laboratory evidence of marked reduction in susceptibility to our monoclonal antibody therapeutics. Next slide. So what is the state in the US right now? So the B117 UK variant is currently the most prevalent variant of concern. So there have been over 20,000 cases as of the end of March, and they are reported in all jurisdictions across the United States. 2 other variants of concern, the B1351, which is known as the South African variant, and the P1, the Brazil variant, are present at around 500 cases in the US and are not seen in all jurisdictions just yet. Next slide. On this first slide, you see the B117 in Ohio. We have a substantial amount of cases, but we are not the highest. Next slide. And this shows the prevalence of the P1 and the B1351 variants. So again, Ohio is seeing cases of these, but it is not at high levels, and there are still states that have not seen this. Next slide. This chart here demonstrates really the time evolution of how these variants are spreading across the country. So I'll call your attention to the peach or light orange color on this graph, which is the B117 UK variant. This graph starts in mid-January and goes until the end of March. And so it's clear to see on here the time progression of the amount of cases or prevalence of the cases of B117 in the US. And you can see the substantial increase from 1 to 2% in January now to about nearly 50% at the end of March. Another important item to note on this graph is you can barely see a maroon or dark red line on these charts. So in the early days, it's not apparent. In the later days, we're seeing a small amount. This is the other variants of concern, so the P1 or 1351 variants. Again, noting that they are not at high prevalence right now, but you can see the absence and now the visibility of those variants in the US. So it's a time course that we need to monitor in terms of how prevalent those cases will be. Next slide, please. This chart here shows the prevalence of the substitutions of concern. So the B117, the others are lineages which can exhibit a variety of mutations that characterize their spread and the risk of treatment failures. These mutations here can be present in a variety of lineages. So this is important to track as well because these can emerge in new lineages and they can cross lineages where they otherwise were not. So again, end of March here, the E484K was at about 10% across the country and the L452R at about 18%. So again, emerging and present in multiple lineages. Next slide. So what's going on in Ohio? So this graph here, I would focus your attention on the blue towards the side, to the right side of the graph. So that blue color is the emergence of the B117 variant in Ohio. The dotted line is the past 60 days. So again, you can see the amount of blue as we move to the right has substantially increased in Ohio over time. So similar to what's being seen across the country. Next slide. So that takes us to what's going on in UH and specifically locally. So as we saw these sequencing emerge, as we saw this variant identification go on, we worked to develop an algorithm and think about how we would assess the presence of variants within our population. So this has been led by Dr. Navid Sadri, and we have developed a variant identification algorithm. So what we're doing here is we take all COVID positive samples from UH, so from all of our hospitals, the community hospitals and CMC. We route them to the central lab. We extract them on a standard platform, so they're entering into our variant testing algorithm in the same manner. From there, it splits into two different approaches. So we rerun them on one of our standard COVID testing methods to assess the relative viral load. It's important to note that we can really only sequence or identify these variants in samples that have a high amount of virus present. So we assess that to know if it's worth moving them further through the process. The attack path assay that I list here also has the capability of identifying a particular characteristic of S gene dropout that is associated with the B117 variant. Additionally, in this algorithm, we screen for some of these substitutions of concern or other point mutations that are characteristic in identifying the specific lineages. So in this screening method, which again, it's cheaper, it's faster, and it allows us to capture variant identification in the breadth of everything that's coming into the UH system, we can get an identification of the likelihood that we have a B117 or another variant of concern. And then many of these will go on to full genome sequencing, where we can see the full spectrum and compilation of the changes in sequences that are present. Next slide, please. So what have we seen? So this graph here, the blue bars are total positive cases. The red bars are B117 cases, and these small colors that are barely visible are other variants of concern, which again, they are not highly prevalent in our population. The orange line represents all variants of concern as a percent of our positivity rate in the UH system. So what you can note here, the graph starts at the beginning of February, which is when we introduced this program, this variant identification program, and you see very small numbers of B117 variants. As you move to the right to the end of last week, you can see that the B117 variant accounts for a high percentage of our positive samples in our population. And as we track this over time, again, you can see the increase in variants of concern starting at the end of February, now accounting for over 60% of positive cases in the UH system are due to variants. So why do we test? And that's really a key question here. We primarily are doing this for epidemiological purposes. All data is shared with the state directly, and the state will share it and track it with both the CDC and the local public health entities. But also we found that we want to use this data to, we'll call it a track and act. So what we've been able to do with this data in the early days of March and late February, what we found as we started to see those red bars emerging, as we started to see cases here, we found that they were clustered very heavily in narrow set of zip codes. So with this, we were able to partner with our community colleagues, clinicians, as well as some other community entities to target testing and rapidly respond and provide testing for those groups where we were seeing rapid spread and rapid emergence. So again, that's a great way of being able to use this identification to actually have direct and immediate impact on the communities that we serve. Next slide. Okay, so then positivity post-vaccine. So again, that's really the spectrum of variants, which is the highest set of questions we're getting right now. But as vaccines thankfully are more prevalent and we have more people vaccinated, we're getting a lot of questions about positive tests post-vaccine. I will say that the majority of questions come and it is identified that the patient has not met the criteria for being fully vaccinated and that 2 weeks post the second dose immunization. So they are still having a positive result in a period where they're not considered fully immunized. So, but of those in positive results in our limited set here at UH that have been vaccinated, we have identified 7 positive cases in individuals that are at least 1 month or more post-vaccination of their completion of their full dose series, whether that's 2 or 1, depending. So we've had 5 cases that had the Moderna vaccine and 2 cases that had the Janssen vaccine. So what we're learning, again, in this limited set post-vaccine is that these individuals are exhibiting fairly low viral burden. And we had, so all of these, as I said, are feeding into our variant identification program. So anything that comes in our system, vaccinated or unvaccinated, has an opportunity to be assessed for variants. But what we're finding is that these post-vaccination samples have fairly low, so orders of magnitude below what we would typically see in an unvaccinated positive individual. We did identify 2 cases of variants listed here, but again, the majority were too low to test. So what that means, I think, needs to be assessed and borne out over time as to what we can conclude from risk of actual infection as well as transmissibility. Next slide. All right, transitioning to the other set of questions, which is about antibody testing. Here at UH currently, we do have an orderable IgG antibody test. It happens to be targeted against the nucleocapsid antigen. So this test is able to assess natural infection, but cannot detect a vaccine response. There do exist assays which we have evaluated against the spike protein, the spike gene and antigen region. These can target the RBD, the S1, S2 regions as well, and these can detect and assess vaccine response as well as natural infection. But importantly, it cannot differentiate between the two. What we know about the relative action and significance of the nucleocapsid-directed antibodies versus the spike antibodies is that the spike antibodies in laboratory studies tend to correlate better with neutralization than the N antibodies do. The chart on the bottom just demonstrates the prevalence of antibodies that are, again, unsolicited, just orders by our physician population. And you can see the increase to approximately 30% of our tests are positive for nucleocapsid-directed antibodies as we moved through the surge of cases in the December-January timeframe. Next slide. So I won't go into too much detail here, but really this is put out here to to communicate the concept that the nucleocapsid versus the spike antibody tests have a differential utility as well as some shared utility. And when we think about application of antibody testing, we want to break down symptomatic versus asymptomatic. Are they vaccinated versus unvaccinated? Do they have symptoms or are they exposed? And this can lead to a conclusion of which of these tests is preferred over the other, if there is a preference, or whether there is or is not a need to test. So as we continue to communicate some of these things, we will add this type of information to our FAQ documents that are out there. And an important reminder, right now, the current CDC recommendations do not support post-vaccination assessment of immune response as routine, but the questions we are seeing are really consideration in immunocompromised individuals. Next slide. So where are we with this? So we do intend to transition to our primary orderable test being the spike antibody. We anticipate this will happen about mid to late May. But we do feel that there is still going to be a need to have the nucleocapsid test available. We aim to transition to the spike testing because this captures, again, both natural infection and post-vaccination, but we recognize there are certain circumstances where it will be necessary to differentiate natural infection from post-vaccine, so in cases of MIS-C and others. So that will be coming out. So in the interim, before we have that test available, we always encourage you to contact us to talk through your case and the clinical need for testing at our consult service information that I list here. And next slide. And so the last thing I want to cover just briefly is the impact of variants on diagnostic tests. So this is something obviously we in the lab are very alert to and looking out for, is this potential risk of failed detection if mutations occur in certain regions that are targeted by our PCR tests. So I list out the methods here and the specific genes that they target. The majority of methods do target multiple gene targets, and fewer of them target the S gene, where we are seeing the majority of mutations in the lineages right now. One method has actually used this S gene, this failed amplification for the S gene as a marketable feature to differentiate potential B117, but the other tests are successful. We are keeping our eye on the potential emergence of mutations in some of those other genes that would portend potential failure in our assays. Antigen failure is theoretical at this point. The common methods out there target nucleocapsid antigen. And then the antibody test, again, theoretical at this point. There are methods targeting various antigenic regions, but there has not been documentation of failed detection in those antibody methods. And I believe that's all I have. So thank you. So I look forward to taking questions at the end, and we will turn it over.
Awesome. Thank you so much, Dr. Schmotzer. That was phenomenal. So now he doesn't need an introduction since I think everyone here on the call knows him, but this is Dr. Salata. So Dr. Salata did his residency training here at University Hospitals, went on to the University of Virginia for ID fellowship, came back here to do his chief year here at University Hospitals, and currently serves as the chair in the Department of Medicine. Aside from that, he's also an expert in infectious diseases, so we're lucky enough to have him talk on mRNA vaccines today.
And principal investigator of the Pfizer vaccine trial at UH.
So Dr. Salata, I'm happy to advance your slides, so just let me know.
Go ahead, Kiara. So let's start with this, and it's fortunate for me to be following two great presentations about contemporary issues that have emerged in the COVID setting. This shows you a heat map, if you will, of the United States, and the more red, the more cases, and you could see that Michigan stands out as the most, is the new epicenter in the United States. And fortunately, this has not necessarily been the case transporting infections over the border to Ohio, but Michigan's really struggling with this right now. There are other areas where there are pockets, but Michigan is the most important one. If you could advance, next slide, please. So for Ohio, showing a yellow light, you can see that we've bumped up a little bit in the more recent time frame. And this relates to an 11% increase over a 14-day period out to this point in time. Deaths and hospitalizations have also changed in this period. One of the things, if you look over a longer period, is that deaths have lagged, which they often do. And the ICU admissions have been fewer, although still significant. I think that reflects the fact that many of the cases that have been more recently admitted to our hospital have not necessarily been those at or greater than the age of 65. Keith is tracking this data very carefully, and that likely represents that a significant portion of those folks, well over 60%, have already been vaccinated. So it's another example of how vaccination can impact on rates of COVID. Next slide, please. So we are really looking forward to light at the end of the tunnel. We're going to speak about some of the vaccines, particularly focused on the mRNA vaccines today. We had a great discussion by Lalitha about the newly recognized, albeit rare, consequences of the adenovirus-related vaccines. And Novavax has not yet been evaluated by the FDA for release, but it's been studied worldwide. Next slide, Kira. Shows the differences in these vaccines. We have two major types, well, actually three. The RNA or DNA-based vaccines are initially here, with the mRNA-based vaccines representing Moderna and Pfizer. The technology for this, it's important to understand that this has been studied for over a decade. It was mainly being developed in Germany for the purposes of evaluation for cancer treatments, but it had been used in a few attempts using the mRNA technology for other vaccines in the past, namely Ebola, as well as influenza. But this is really the first time this has emerged as a major approach. Come back to that at the end. There, the spike protein is indeed incorporated into the mRNA, and the mRNA, once it's incorporated into the cell and it's protected through a lipid nanoparticle layer, because otherwise mRNA disintegrates rather rapidly. Once it's in the cell, that happens, but it still presents the protein to the outside covering of the cell, and the immune response that thereafter occurs. This is contrasted with the adenovirus vaccines. The AstraZeneca is a chimpanzee adenovirus that does not replicate in humans. And Johnson & Johnson is a human adenovirus, but it's been attenuated, so it doesn't replicate either. This contains the gene for the spike protein, et cetera. Novavax, on the other hand, is a protein-based vaccine, as we use in other settings. And the last are inactivated vaccines that the Chinese have primarily utilized. And those have been recently reported to be inferior overall to the approaches taken with the mRNA or the adenovirus vaccines. Next slide, please. So Christine did an outstanding job speaking about variants of concern. The most common now is the B.1.1.7, which now represents about 50% of all newly diagnosed cases in the US. And there are changes. It should be noted that there have been over 4,000 mutations described in the coronavirus since its first recognition. But it's been more recent that changes in the spike protein have been recognized. And as such, that was the point of focus for the immune response, in part based upon studies from way back with SARS-1 as well as MERS, because when an immune response developed against the spike protein, it seemed that that was really consistent with aversion to infection and recovery, et cetera. And that turned out to be absolutely right in terms of that target. It is also the case that the spike protein does attach on the human cell and then is taken within. And that's the mode of pathogenesis for this. And the variants are a little bit different. But Christine went over that. I won't belabor that. Next point. Next slide, please. So again, we saw Christine show some data about the variants and their impact on hospital admissions. Michigan, again, not to pick on our colleagues there, but this is what's happening. And the share of cases due to the UK variant is about 70% now. This is also increased in accordance with looking at new cases per 100,000, et cetera, et cetera. So Minnesota represents another example where this is happening. Next slide, please. And then let's start talking more about the vaccine, because indeed, this is a race between getting a sufficient number of folks vaccinated versus increasing cases and the emergence of the variants. Again, despite the fact that Michigan has the highest number of new cases now, they're kind of in the middle, but approaching a higher level, certainly more so than the United States. And there are some states that have really done an outstanding job in terms of vaccination of at least one dose. Next slide. And here's the US total of folks that have been given at least one dose at 40% and increasing. And we went over the 200 million point recently in accordance with the Biden administration's goal. Ohio is just lagging a little bit behind. Fully vaccinated still lags, but we have to increase that accordingly. Next slide, please. The other important thing is we will talk about the issue of herd immunity and not only what that means, but also how to get there. This is data from the CDC showing over time the number of vaccines per day that are being administered in the United States. And it really is the goal to get above 3 million, which we've done. However, just 2 days ago, a recent CDC report showed an 11% decrease in daily vaccines administered. Some of this, relates to the Johnson & Johnson halt. Some of this relates to the continued vaccine hesitancy, and the J&J situation has, really, I think, provoked the anti-vaxxers to some extent, if you look at the literature, and et cetera. But that's where we're at right now. Next slide, please. And very importantly, it's really felt that we need to be at least at 75, if not 80% vaccinated to reach herd immunity. So it is now estimated, given the current rate of vaccine administration, that we'll reach that level somewhere in the second or third week of June, and certainly by early July and beyond. But there's a substantial segment of the population, still the children, that we're awaiting new authorization for the 12 to 15-year-olds by Pfizer. They've completed those studies with 100% efficacy and similar side effects to the adult side. And we will see what happens in this regard. It used to be felt that we would potentially approach herd immunity in the fall or by the first of the year, but stay tuned because that's the current pace. Next slide. And the other issue that impacts vaccine use is the hesitancy. And you could see Ohio is around 25 to 30% of the population, especially in the southern areas where there's hesitancy, as well as a whole spot of states in the northwest corner. Next slide, please. And then let's not forget, this is a global problem, of course. And if you look at vaccine use in most of the Western countries and in Europe, we're doing relatively well. But in some of the resource limited areas of the world, I think this remains a major challenge, not only in terms of access to vaccine, but storage capacity, administration, et cetera. I spoke to my colleagues in Uganda just at the beginning of the week. They're starting to use the AstraZeneca vaccine there, but we know about several of the clouds that have surrounded AstraZeneca, and this has not been reviewed yet for use in the United States by the FDA, so we await that happening. Next slide, please. So also the other thing to mention is where the US stands with regard to other countries. The one that where there has been an incredible success rate in vaccinating has been in Israel. And more recently, in that they use primarily the Pfizer vaccine there. There have been a number of studies published, especially out of Tel Aviv, that shows real life experience with this vaccine, and it's been absolutely outstanding, both affecting symptomatic and asymptomatic infection. The symptomatic infection was decreased by 94%, and we're going to derive much more information from Israel, as they have two major HMOs and can track this information very carefully. But we're still behind other countries, including the United Kingdom and Chile. Right now, we have a ways to go. Next slide. And at UH, in terms of our vaccine facts, we started vaccinating on the 23rd of December, and this gives us data out to the 24th so far. And the first wave, 1A, which were mainly caregivers, we've administered 37,383 doses. Remember that our workforce is about 28,000. There was the opportunity to expand beyond that. We have vaccinated significantly also 47,000, about 48,000 in our high-risk patients, total of 85,000, and we're capable of doing up to in greater than 2,000 doses daily, and we're moving from there. But although we've had some halt in the numbers of people taking, making appointments, et cetera. So that's another thing that's happening nationally. Next slide. So let's get back to the mRNA vaccines. And I just was on a call this morning with the Pfizer hierarchy about a number of other things planned. Just recently in a study published at the beginning of the week with the Pfizer vaccine in pregnant women, there was outstanding, as we expected, outstanding efficacy and safety, including and especially utilized in the third trimester. They're going to expand this information to individuals that are in women that are in earlier trimesters. And this is being taken outside the United States, where the major vaccine trials have been done. We are currently involved in giving booster doses of the original vaccine, and the individuals that were vaccinated in the phase 3 trials about 5 to 6 months after the second dose. We are one of 42 sites worldwide doing this with the Pfizer vaccine, as mentioned. The idea here is that when studies have been done in the laboratory right now, looking at the blood and neutralizing antibodies from individuals vaccinated with Pfizer and Moderna, that they've been able to neutralize these variants in the laboratory setting, less so for the South African variant. And it's felt that boosting the immune response even more so may overcome some of that reduction in the neutralizing capability, especially of some of the variants, and also may provide a longer time period, obviously, in order to establish whether or not vaccine boosters will be important in the future. The data reported so far is that both for Moderna and Pfizer, though the rates of protection at 6 months remain very high, They're not quite as high in the original phase 3 trials. And whether or not over time we're going to need boosters, and whether it's going to be with the original vaccine, or as we're doing in another arm of this new study, we're looking at new generations of vaccines that are being focused on the South African variant. We've mentioned that several times. And we are doing this trial right now. These are in unvaccinated individuals to date. And to that end, this will be important. We feel that this vaccine, even though it's focused more on the South African variant, will still provide cross-reactive immunogenicity against the other variants. That remains to be seen. The other thing on the call this morning we're talking about is continuing to evaluate new generation vaccines, including the possibility of doing multivalent, incorporating multiple components of the variants in vaccinated individuals. There are plans to undertake trials of immune-compromised individuals in vaccination and effectiveness. There's a recent publication from Johns Hopkins that included, I think there was a comment by Brenda Cooper or a question from her about bone marrow transplant patients, but this included solid organ transplant patients as well. And using the mRNA vaccines, there was a immune response, antibody response, neutralizing antibody response of only 17% after a single dose. We're waiting for further studies of completing the second dose and where that stands. But I think new strategies for immunocompromised individuals will have to be considered. Brenda asked also whether if somebody undergoes a bone marrow transplant, should you revaccinate? I would guess, Brenda, the answer would be yes, as we do with other vaccines. The exact time period after the bone marrow would probably be related to the current recommendations for other vaccines as well. The other very exciting thing is with the application of the mRNA technology, first of all, as you've seen with the use of the new generation vaccines, this can be easily manipulated and new vaccines created quite readily. And we also are considering the mRNA technology for other vaccine development. For instance, on the call this morning, again, they're developing a new pneumococcal conjugated vaccine that utilizes the mRNA technology. There's also some interest in looking at this in development of vaccines against malaria. And also the application to cancer therapy, again, has been reimagined because of the success of this technology in the COVID scenario. So I'll just stop there. That gives us a little time, Kiara, for questions. May I ask one? And that is to Lalitha. Do you want to speculate about the pathogenesis of the VIT phenomena? Why is this happening? Do you have any ideas?
Yeah, so I knew I was going to be asked this question, so I prepared a little. So the answer is we do not know, but I do not think it is based on the adenoviral vector. And I say that because the Ebola virus has used, and there are other vaccines that have used the adenoviral vector, and we have not seen this entity. So I almost think it might be something to do with the spike protein. Whether it's a bigger burden of the spike protein, whether it's something of the sort, we do not know. But that is what we are waiting for. It is some kind of immunothrombosis. For some reason, it just sets our inflammatory system. It instigates us, and we do not know.
Yep. Along the same lines, what's the role of the PF4 antibody?
So if you see in autoimmune hit, there are other things that can activate, or antibodies to PF4 can activate platelets. So these are activating antibodies. You do not necessarily need to have HIT or heparin on board. I almost think HIT was a way for us to understand immunothrombosis and how antibodies generated against platelets would activate platelets and then cause this immunothrombotic phenomenon. So okay. I think there are other things that can cause antibodies which would then activate platelets.
And one quick comment on the adenoviruses, the Ebola was using about 200,000 people, and it was in West Africa. So they might have
Yes,
not had enough cases or missed cases because they don't have the technology to diagnose it anyway.
that is true. That is true.
The same
But
thing
for
with the
now, we
Congo
don't believe.
as well.
I'm sorry.
Same thing with regard to its use in the Congo
Yeah.
or contemporary. Yes, I agree.
Yes, I agree. We have not vaccinated millions of people like this, but for the present, at least, we do not have any reason to believe that it is an adenoviral vector-based effect. But again, this is new. We're new to this game.
And most people probably know that the Advisory Commission on Immunization Practices is meeting as we speak
Right?
Yes, yes.
to discuss the fate of the J.J. Johnson. It was the Johnson & Johnson vaccine until there was some complications, and suddenly it was the Janssen vaccine. Anyway.
Well, Janssen is the parent company, so they shot it up the ranks.
Yeah, and then there's a comment from Neil Greenspan in the chat about again this pathogenesis and the difference between the mRNA and the adenovirus, which could be significant. And Dave Kennedy, Dave Kennedy commented, but Neil kind of raised that question anyway. And I think there's a couple questions in the chat that Dr. Salata answered.
Let me just comment on one by Hillary related to mixing and matching vaccines.
Okay.
There is.
Okay, great. Well, I was able to figure out the technology, which is the.
Yeah, there you go. You're muted now.
Yeah. So the bottom line is the UK is currently doing an ongoing trial where they're mixing and matching vaccines, including adenovirus and mRNA vaccines, excuse me, and we should have some information soon. Right now, it is not the recommendation to mix and match these or mix these vaccines. Theoretically, it may be possible to do that with the Moderna and Pfizer vaccines, but I think we'll have this information forthcoming.
Bob, do you have any comments on the last question in the chat?
So there's no, because this does not replicate either the chimpanzee or the attenuated human adenovirus, there is no integration into the genome. And that is really important to emphasize for the mRNA vaccines, particularly that disintegrates pretty rapidly within the cytoplasm once that gets into the cells. One of the problems with the mRNA vaccines now and in the future is the storage issues, and that relates to the fact that the mRNA is pretty fragile, and therefore it's surrounded by pegylated material as well as lipids and nanoparticles to keep it intact until such time as it can get into human cells. But that does not last either. It does not cause any concern about changing integration into the genome.
I got a question texted to me about the vaccines helping, long COVID, post-COVID syndrome.
So first of all, not to take up too much more time, but under the championship of David Rosenberg, and many of you may know him as one of our community-based pulmonology folks, we are going to stand up a post-COVID recovery clinic. We don't like to call it a long hauler. That has different connotations. It's going to be a multi-disciplinary approach and so on and so forth. But regard to that question, there have just been some case series, Keith, where up to 30% of individuals who have been really beset with major post-COVID complications, even 12 weeks or longer, when vaccinated, about 30% of them seem to have resolution of their symptoms. And people have speculated there may be residual pockets that is not necessarily representative of active viral replication, but persistent viral products in the body, and that the T cell response that occurs, we've been talking mainly about antibodies, but T cell response is also very important in terms of potentially eradicating that. But one of the things we're going to do here, just to finish, is Grace McComsey from our Clinical Research Center is going to set up the capacity to do clinical trials in that group of individuals, trying different therapies, and we'll go from there.
Awesome. This was an absolute phenomenal, hour and 3 fantastic presentations. I can't thank you guys enough. We hit 300 on the Zoom, and it turns out that's our capacity. So I'm getting a lot of angry emails and texts, and we'll be sending out the link to the recording as soon as we can. So really, just thank you so much to our 3 presenters. Really awesome. It's almost 5 after. We should probably in things.
But given the
any last
level of
comments?
interest, Keith, we should probably do this again.
Yeah, fantastic. Yeah, the interest was, I over advertised, I learned a lesson. I didn't anticipate this 300. Anyway, thanks guys. It was awesome.
Thank you so much.
Thank you.